It's 12 now, and I think we should start the meeting.
Okay. Shubha Madhyana, all of you. Myself, Dr. Hemant Pansade, Organizing Secretary for Naidaniki Webinar September Series. Before I start, I would like to invite our spokesperson, Dr. Muyar Boyar Madam, to introduce our organization. Over to you, ma'am.
Thank you, sir. Good afternoon and namaste to everyone. Myself, Dr. Mrunal Bhoir. I am the Associate Professor and HOD in Rog Nidan Department, Parul Institute of Ayurveda, Vadodara, Gujarat. And I am here to give you a brief introduction about Rog Nidan and Vikruti Vidyan Postgraduate Association. So our association, RVPGA, was formed in the year of 2016 under the able and dynamic leadership of respected Dr. Subhash Waghe sir, with the aim to give the legal status to pathologists and radiologists and also to the PGs of Rog Nidan all over the India. Our organization is duly registered under the Societies Act of 816 at the Charity Commissioner Office, Nagpur. Postgraduate students, teachers of Rog Nidan and Vikruti Vidyan can become our member. Ours is the only organization which is fighting for the lawful rights of Rog Nidan PGs. Even the NCISM, the National Commission for Indian Medicinal System, has also directed State of Maharashtra to consider RVPGA as a stakeholder in the constitution of pathology regulatory body of the state. RVPGA is pursuing this matter with state and also with the central government. Not only this, RVPGA is constantly pursuing the implementation of NCISM salary structure in all the private medical colleges across the nation. All the communication, all the announcement are uploaded duly on our website www.rvpga.com. Some activities I am mentioning here. First, the regular conduction of online webinars and offline seminars, both at national and international platform. Hands-on training program for our PGs at our partner NABL accredited pathology laboratory at Mumbai, Nagpur, and so at Pune. Publication of research papers, articles for the Nidan students and faculties in our peer-reviewed international journal of diagnostic and research called as IJDR. Interested can visit the general site www.ijdrindia.com. Edited book volume series through our international publication RIPI, which is registered in Government of India's ISBN portal. Those who want to contribute a book chapter can visit RIPI website www.rvpgai.com. I'm repeating this, www.rvpgai.com. We do legal fights for the issues of Rog Nidan and Vikruti Vidyan PGs at appropriate forums. We have our YouTube channel and Facebook page where you can see all the educational activities conducted by the association. This is all for the activity and our association. Thank you. Over to you, Dr.
Thank you, ma'am. Thank you so much for precisely introducing our organization. Now, we are having two eminent personalities, Dr. Subhash Waghe sir as a guest speaker and Dr. B.R. Poddar sir as a chairperson. Before I call, I would like to invite Dr. Archana Kulkarni madam to welcome and introduce our today's guest.
A very good afternoon to all. First of all, I would like to welcome Dr. Subhash Waghe sir for today's first lecture of this September month webinar series, Naidaniki 2023. I feel extremely honored to introduce our guest speaker, Dr. Waghe sir. He doesn't require an introduction as he is a well-recognized personality in the field of Ayurveda. Sir has completed his UG from Government Ayurveda College Nagpur and PG in Rog Nidan from Sri Ayurveda College Nagpur and is PhD scholar at MUHS. Besides this, Dr. Waghe sir has 10 other degrees and diplomas to his credit. Sir has published 50 research articles in various peer-reviewed ISSN journals and presented many research papers at various national and international conferences and received the award for the best paper twice. Sir has written 21 Ayurvedic books, revived 8 lost Sanhitas of Ayurveda, and was felicitated at Latur by the Ayurveda Update Group for the same. He has been awarded for the best book twice by the Ranade Foundation in Pune. Sir has also received the prestigious Vaidya Yadavji Trikamji Grantha Puraskar from Vaidya Khadiwale Pratishthan Pune and various awards like Dhanvantari Award, Best Global Teacher Award, and Best Researcher Award. Dr. Waghe sir was a member of the team for framing the Nidan Dictionary by the Government of India. He has been invited as a resource person to many national and international seminars and conferences and has delivered lectures for international delegates from Brazil, Portugal, and Russia. Presently, Dr. Waghe sir is president of the RVPGA organization and a life member of the many other organizations. He is editor-in-chief of the IJDR journal and is on the editorial board of many peer-reviewed ISSN journals. He is also editor-in-chief of RVPGA International Publication. We would like to welcome you, sir. I also welcome Dr. Poddar sir as a chairman for this session. Today, Dr. Waghe sir's topic for this session is gait and involuntary movements in the neuromuscular disorders. Now, I request Dr. Waghe sir to deliver his lecture. Over to you, Waghe sir.
Thank you very much, madam, for precisely introducing me. I did not so much precise introduction. Okay. Our today's topic is gaits and involuntary movements in neurodisorders. Before actually starting the topic, I suppose many PG students are also be joining us, or if not, they are going to see this video again on our video channel on YouTube. So for them, I just want to give some introduction and then followed by this demonstration of these various gaits and involuntary movements through some videos. You will be amazed to know that the gait word is evolved from our Indian word gati. Gati. What is gati? Gati, that is defined in Samudrik books, is Sukha Sancharit Pada. And one more request before I actually start, one more request to all the audience to keep their audience mute so that there is no disturbance in the lecture. And so what I was referring to, what is gait and what is gati? Sukha Sancharit Padayaha Gatihi Syat Gati. So the distinct walking pattern that is referred as the gati. And there are many such normal and abnormal walking patterns. They are described in Ayurvedic and Samudrik texts. Particularly referring to the Ayurvedic texts like Charaka, Sushruta, they have described the gati, distinct pattern of walking with respect to particular prakriti saras. For example, the kapha prakriti individuals, they are slow in walking, and they are going to achieve the great wealth. And suvyavasthit gataya, the word they have used to indicate the sattvasara purushaha. Susamahit gataha sarvesarahi upadrutaha, sarvasar purusha. So likewise, I mean, they have a normal pattern and the attractive pattern of walking. Whereas Acharya Kashyapa, in his book Kashyap Samhita, there is a chapter of Samudrik Lakshanas, the body features, and they used to predict the future of the individuals also based on these observations, how the particular walking person is going to perform in his future life also. This is very interesting. And Acharya Kashyapa accordingly mentioned that those who have the slow movement, they are going to achieve the great wealth in the future life. And those who are having the Chapalgataha Sukha Dukha Bhagina, they are alternately going to get Sukha and Dukha's experience. Tiryagataha Adhanyaha, those who are having the abnormal walking pattern, they are not going to get the great wealth. So likewise, we see this in some conditions. Likewise, in abnormal conditions also, they have mentioned some gates. Acharya Vagbhata and other our acharyas is in Kalai Khanja, Khanjaiva, Prakamati Vepate, Kampate, while starting the tremulous gate in Kalai Khanja, claudication, there is intermittent claudication, and Pakshaghata Chankraman, then the limping gait in Grudhrabhat Chankraman in Grudrasivadi. And you see some abnormal distinct patterns they have described by in Nrusti Samudrik Shastra also. Esham Karambagati, Esham Bhekagati, the frog-like walking, the camel-like walking, and Vishamaha Laghu Kramaha cha. Likewise, the shuffling gaits with small shuffles. So we observe all such different types of gatis in ancient reference to different types of gaits and gatis in ancient books. One more thing, Acharya Kashyapa has told that the person who walk like a cat, or walk like a lion, a Vrishab, a ox, and Hansagati, they're also going to enjoy the good wealth in the future. I mean, by virtue of the good health also. So these are what we are going to see from the ancient point of view, and from modern point of view also. We are going to see the circumdacted gait in hemiplegic patients, unilateral hemiplegia, wherein the gait is circumdacted, ball of the great toe rubs the ground, and where the affected hand is flexed from the elbow, abducted, and the wrist is pronated, the typical gait. Again, in Parkinsonism, we are going to see the shuffling gait, wherein the patient walks in small shuffles, and when he turns around without lifting the leg, and the face is expressionless, and there is no arm swinging. While we walk, there is arm swinging, but in this patient, there is no arm swinging. We are again going to see the waddling gait, which we observe in the patients of Duchenne's muscular atrophy, which is a pseudomuscular hypertrophic dystrophy of the calves, wherein the patient walk like a pregnant lady, or waddling of duck, wherein the buttock is rotated abnormally through high arc, and that typical gives that moment gives rise to the waddling of the duck, this type of. And then we are going to see when this patient, they lose the power to stand erect, they crawls on hands, and that gives rise a typical frog-like gait. And again, choreoform gait is one such gait wherein we are going to see some involuntary movements, wherein there is choreo, which is sudden and brief, jerky, abnormal movements. When such individuals they walk with the tremulous body. So incoherent walking you notice in such individuals. There is reeling gait, reeling or ataxia gait, which what you notice in alcoholic intoxications. There is frontal lobe gait, wherein there is ataxia, patient walks on a broad base. And there's a few more gaits we can discuss about. Similarly, there are involuntary movements which are not under voluntary control. In this, under this, we are going to see the tremors, which can be classified into the resting tremors. Those what we observe in Parkinsonism, and senile patients, senile individuals, those we have the tremors at rest. Then action and intention tremors. Action and intention tremors, they are more or less the same, because when the limb is kept actively in a certain position, or when certain object is intended, the hyperkinesis is marked. So in alcohol withdrawals or in addictions or in hyperthyroidism like conditions, we can, or cerebral diseases, we can get such type of tremors. Historical tremors, they are bizarre tremors. When the affected hand is restrained by the examiner, the tremor starts in another hand. Then chorea, which I already told that it is a sudden, brief and jerky moments which are observed. It is basically the disease of caudate nucleus and putamen, which can be resulted due to the birth injuries or encephalitis or vascular injuries. Or it can be metabolic also. It can be endocrinal, such as in hyperthyroidism. It may be due to Wilson disease, excessive deposition of copper. There is particular typical wing beating tremors we may get. It could be rheumatic also, that as like in Sydenham's chorea, or it can be hereditary as Huntington's chorea. Another one is athetosis. It is also the disease of caudate nucleus and putamen, which is characterized by slow movements, which is slow rhythmic movements. They are little bit continuous one, associated with hypotonia, and the movements typically they involve the alternate flexion and flexion extension of the wrist. This you get in long-standing hemiplegia and the other causes which are enumerated in chorea as well. Third is hemibelismus. It is a disease of nucleus of Lois, and the movements, they are jerky and violent nature with wide excursions, typically on the arms. Means typical amplitude is greater at the shoulder and the hip. The swinging and violent type of nature. We are going to see that. Fasciculations, another, they are absent at rest but can be brought about by the mechanical stimulation. There are fine twitching moments observed in motor neuron disease or demyelinating diseases because of abnormal firing of motor neurons that have lost their nerve innervation and trying to connect the nerves. Another is fits and convulsions, which is commonly noticed in diseases like epilepsy and even in the raised intracranial tensions with tonic-clonic features. So these are in short what we are going to notice in this short lecture, but these will be of importance to the students, will be of immense help to them to differentiate the condition and to see how exactly they look. We are going to involve myocamia, astrexis, etc. also, wherein there is a flap myocamia, there is twitching movements of the perioorbital muscles also. So let us see all those, and let us discuss those. I'm going to share my PPT now. So as I mentioned, the Supasanchari Pada Syat Gatihi, that is the definition of Gati given by Nrusti Samuddrik Shastra. And Gati is the distinct pattern of walking of the individuals. Get examination technique, who observe the patient while walking, and if there is abnormality, you can ask the patient to run also. If you want to, one thing I forgot to mention, that if you want to examine the stance, ask the patient to remain with his feet close to each other with eyes open and eyes closed. Then see whether patient staggers or sways. That is what we conduct a rhombus, what we exactly conduct in rhombus text. And you can see the retropulsion of the patient also, pulling back the patient and asking him to resist. That way also that can be assessed. So this is what I told some of the normal walking patterns in in Kapach Prakriti individual, Ashigra Aramba, Suvevastit Gataya, Guru Gataya, etc. And in Sarvasara Purusha, Stirasu Samahit Sharira, Susamahit Gataya. Very well organized pattern of walking, what we can see. Again, in Satvasara Purusha, Suvevastit Gati, they have mentioned. This in Kashyap Samhita, this is particularly with reference to the Samudrik Lakshanas, but how the individual is going to perform in the life. Matta Gaja Vrishab Siha Shardul Hansagatayo Adipatayaha. They are going to perform like king. And Stimit Gato Dhanyaha, very this slow walking, they are also going to perform, they are going to be wealthy. Chapal Gatayaha Sukadukha Labinaha, Tirya Gataya to Adanya, this I already told. And let us see some abnormal patterns of walking in Samudrik Granthas and Ayurvedas. Laghukrama Manda Vishama Gatihi. Stabdha Manda Vishama Laghukrama Ashobhanan. In inauspicious moments, they have told this moment, they have observed the moments, but could not attribute it to the Parkinson's disease, but they have typically noted and noted down their findings, but could not attribute to the internal abnormality of the brain. So Manda Vishama Laghukrama Ashubhana Gatihi, Vishama Vikata Manda Laghukrama Chanchala Druta Stabda Gatihi. This is also observed in Manda Laghukrama Chanchala, fascinant. Once you push the Parkinsonism patient, he doesn't stop. He moves. Even with the tremors also. He moves very fast. And one should be there to help him. They are slow in starting, but once started, they doesn't stop. Dekamesha Gatihi, they Gata Sukra, they are devoid of the happiness. What we can say that they're unhealthy. Karab Gati, camel gait, you can notice in facioscapulohumeral atrophy, the typical protrusion of the buttocks that gives a typical appearance of the camel, but nowadays you doesn't get this gait because of good nutrition available. So these are all abnormal gaits and they doesn't enjoy the good health. Now coming to our part, what I told you in hemiplegic patients, because of paralysis of one half the body, the forward projection of the limb is affected and the ball of the great toe is rubs against the ground and the gait is circumducted. Paralyzed arm is adducted and flexed at elbow. I already told you, fingers and wrist of the forearm are pronated. Let us see this patient, how this patient walks. Now let us see this on the patient. So this is also called a circumducted gait because of the half circle the patient makes while walking. Yeah, and you see the ball of the great toe that rubs against the ground. This is limping gait. Limping is observed in the disease called Gridrasi or Shatika. The patient drops the weight on, keeps the legs semi-fused and drops the weight on the affected side. With short steps, keeping the painful limb semi-fused and dropping the pelvis towards painful side, patient walks. Let us see how this patient walks. See limping on. Turning also we can notice. This is typical limping. So this is shuffling gait, which I was referring to, which is commonly observed in Parkinsonism. See where the patient's face is expressionless. Patient can be with tremors, and patient walks in small shuffles. There is no arm swinging, and while turning, the patient turns without lifting the leg, which is not commonly observed. So this is because due to the rigidity, and you can notice this in extrapyramidal diseases like Parkinsonism, where the organization of cerebellum is affected.
Sir, can you zoom it?
Now let us see this on the original patients. This old man, this, see how he starts. This is very difficult in starting. Even when once push, there is a fast walking with tremor. It is associated with the tremors also. You can see just when pushed, he doesn't stop. Checking pulse is there. Now let us see another video of this old lady. She's walking in small shuffles. Now while turning also, see how she turns without lifting a leg. She turns on the ground itself. Let us go to the other gait that is called as waddling gait, which is noticed in pseudomuscular hypertrophic dystrophy, wherein there is the pseudomuscular hypertrophy of the calf muscle, and patient walks like a pregnant lady, wherein the arch of the buttock is rotated through a large angle, and both heels and toes, they are brought down simultaneously. Let us see this gait. Let us sit in patient. And there is compensated lordosis also. The walking is appears like to be the dada, जो गुंडा जैसा सीना तान के चलता है ना, वैसे type का. We have seen all these gates in at GS in Nagpur in so many times. That time we could not record it. See how the boy is walking. His calves are hypertrophied. There is a lordosis, dada-like movement. And let us see it in another individual. No, sorry. This is waddling. This is waddling of duck. And like this waddling, the individual moves. Let us see in another video. Here, we can see that waddling also again. Now, the frog gait is in same individuals when there is power to remain erect is lost. And then these boys, they crawl on hands and feet, and that gives a typical appearance of frog-like gait. Let's move forward. This camel gait, I told you that because of scapulohumeral dystrophy, there is protrusion of buttocks and which gives like the camel-like gait, but nowadays we doesn't get it because of the good nutrition. And the pathologies are also rarely seen nowadays. Now, another is the high stepping, slapping gait or high steppage gait because of foot drop. So to clear the foot drop, patient lifts the legs too high and brings it slowly down and like slapping. And there is a the gait is broad base. There is distance between the two legs. That is called as broad base. Let us see how this occurs. Let us see the video of the patient, exact video of the patient. This is action again in high stepping gait. We can see. So this is because of the paralysis of popliteal nerves and or peroneal paralysis. And if it is on both the sides, then both sides are affected and both legs are. First, we will see on patient on unilateral and then on the bilateral sides how it occurs when. First, this is unilateral side when it is affected on the unilateral side. And here we will see the bilateral of which is affected on bilateral side. Now you can see slapping on both the bilateral side here in this video. Again, I will play it because of the problems dorsiflexion muscles of both the legs. Let us move to another one. This is scissor gait. This we can notice in patients of cerebral palsy because there is a great and extreme rigidity. This gait can be noticed. Here we can see this on patient also. Patients of cerebral palsy, the gait is there is a crisscrossing of the legs. So कैंची जैसा appear होता है, इसलिए this is a scissor gait. Let us see on another patient. There is typical crisscrossing of the legs. This can be due to cerebral diplegia, wherein both sides are affected. Now the ataxic gait, this something to tell about this ataxia or reeling gait. Ataxia literally refers to the unsteadiness, but this ataxia in reeling gait, just recollect the individual who is drunken or in alcoholic intoxicated, and how he walks. That disorganized walking can be best correlated with this. Actually, this is only. And in you see in cerebral ataxia, the causes may be encephalitis, tumor. There could be tumor. There could be degenerating causes. There could be vascular causes. And in sensory ataxia, which generally involves the peripheral nerves, the peripheral neuritis, parietal lesions, spinal cord lesions, tabes dorsalis, which is now not noticed. That is neurosyphilisis, which are affecting the nerves. And there could be central one, where there could be a vascular lesions. And there could be labyrinthine ataxia, where is there is labyrinthitis, Meniere's disease, or it could be streptomycin induced. I already requested the individuals to shut down their audios so that there is no interruption. It breaks the link. Okay. Where there is sensory ataxia and midline cerebral ataxia, cerebral ataxia, and central ataxia. These patients can be tested by rhombus test. First, they are asked to stand with their fists close to each other, with eyes open, and then with eyes closed. In sensory ataxia, they are able to maintain the position with eyes open, but as soon as they closes the eyes, they staggers in cerebellar type of midline cerebellar type of ataxia. In sensory ataxia, as soon as they closes the eyes, they staggers. In midline cerebral ataxia, whether the eyes close or open, when patient stands with his feet close to each other, he sways or staggers. In unilateral lesion, patient tends to fall on the affected side. Now, you can see this disorganized walking in reeling gait or ataxia. There is remarkable unsteadiness. Just recall the individual with drunken state. This ataxic gait, again, we can see there's a broad base and there is a great imbalance, unsteadiness here in this patient. We can see there is a broad base. The legs are too much separated. See the individual is how he's walking. This is frontal lobe gait. Again, there is a broad base gait, and initiation of walking is difficult. Patient seems to stick on the floor and tendency to fall backward. This could result because of the disturbance in connection between the frontal cortex and basal ganglia in the cerebellum. and cerebellum. See, the gait is very broad based, and how he's walking, there is unsteadiness and there is tendency to fall. Tendency to fall. This was the same gait which I explained. Now, this is the choreiform gait. Actually, in chorea, you see, there is sudden brief and jerky movements, and when patient walks with these jerky movements, the entire body may appear tremulous. See the walking pattern of these such patients. May I request the individual who had kept his mic on to mute his mic? Let us move forward. Now, coming to the involuntary movements, the first to start with the resting tremors. As it is mentioned in our science also, I just brought out the references. You can see this, the causes are senile tremor, Jarakampa, Parkinsonism, the nervine disorders, diabetic neuropathy, and here they are mentioned in our science also. So this could, how this, the tremors they are present at rest. Another one. This could be familial also. They can run in families also. So action tremors, they are when the when this limb is actively maintaining certain position like this one. When you ask the patient who are addicted to some addictions, say for alcohol or tobacco also, in this patient, when you ask to keep their hands outstretched like this and to maintain like this, then the tremor starts. And in conditions like multiple sclerosis, there is a head oscillating, like simultaneous head oscillating. Now, if you ask this individual to keep the hands outstretched, now the tremor starts. See, these are action tremors. When limb is actively maintained in certain position. Now this finger nose finger test. This is also one form of action tremors when the arm is outstretched and then it brought towards the nose. When you ask this, and in affected individuals, there could be the hyperkinesis. The tremors could be marked as the finger approaches the nose, or there could be a dysmetria or dysinergia. Dysmetria, patient may stop in between and may not touch the nose. Dysinergia, act is not carried out smoothly, but within its constituent parts, he will touch, go like this, and then he will find the nose like this. Now, this is again action tremor when patient approaches the pain, the hyperkinesis becomes marked. So in anxiety also, multiple sclerosis also hyperthyroidism also, cerebral degeneration, Parkinsonism also, and alcoholic complication also, you can get this type of intentional action tremors. The chorea, as I have described, they are very sudden, brief, jerky, involuntary movements associated with the hypotonia. They are the disease of caudate nucleus and putamen, and could be due to brain infections, metabolic causes also there, endocrinal thyrotoxicosis. In rheumatic, there is Sydenham's chorea, hereditary Huntington's chorea. In SLE also, you can get systemic lupus erythematosus, and in Wilson's disease, there is typically beating tremors, pakshi ke jaise, pank phadane ke jaisa, that we are also going to see. And in drugs like amphetamine, levodopa, and lithium, drug intoxication. See the choreatic movements. See the hands. I will have to be the fast. This is case of Sydenham's chorea, rheumatic chorea. So you pay attention on the patient when that choreatic moment will come. See these choreatic moments, sudden and brief, very short duration. This is this very rarely you can get, but get in some metropolitan cities, the patients of Wilson's disease, where there is getting tremors. You can see the carefree in the eyes also. These are typically wing-beating tremors. See. But very rarely you get such patients. Athetosis is also disease of caudate nucleus and putamen, where there are slow snake charming movements of which involve alternate flexion and extension of the wrist, which you can notice in long-standing hemiplegia and in vascular lesions of the brain, birth injuries. See. And typically associated with. See the movement of the wrist. Again, see. Flexion and extension of the wrist. They are very slow movements. but are involuntary. Here we are going to see that athetosis. Pay attention on the wrist, right hand. Slow snake charming, like जैसे सांप की पूंछ है, जैसे स्लो ऐसी मूव होती है, वैसे टाइप का. This hemibalances, which is a disease of subthalamic nucleus of Lois, and these are rapid, continuous, with wide excursions, a swinging movement of violent nature with latest amplitude on the shoulder and the hip. Let us see. This could be due to the brain injuries, vascular lesions in hyperglycemia. See, swinging movements of the arm and leg. Let us see one more time. We will see one more individual. Swinging, violent nature of swinging nature in arms and legs. Let us see in some other individuals, some other patients. See the right leg and right hand. This is hemibalismus. Let us see in another patient. See the right hand and the right leg. There are violent type of swinging movements. This is hemibalismus. So fasciculation, these are very twitching type of movements which are absent at rest but can be brought about by the mechanical stimulation. Typically noticed in motor neuron disease, diabetic neuropathy, syringomyelia, and in hypoglycemia. See the twitch, see the twitch. So, you know, what's at GS in Nagpur, there used to be a lot of patients of motor neuron disease, and our sir, Dr. Asati sir, used to demonstrate this to us very nicely. Fasciculations. Some chest fasciculations you can see. See the twitching moments here. Let us see another individual. See here the twitching moments. See here. These are fasciculations. Clonus by say per se, it's not an involuntary movement, but it is a certain action. It can be included in that. Action. It is form of action tremor. This can be brought about in long-standing hemiplegia just by sharply dorsiflexing the foot. It can be started in the foot, or there could be patellar by sharply pulling the patella. This clonus can be can be demonstrated. They are rhythmical contractions of agonist and antagonist. To maintain the tension, this rhythmic alteration of set of agonist and antagonist occurs. Myokymia. These are twitchy rhythmical movements affecting the periorbital muscles, even the lips also. You will see here in this video the myokymia in lips. See, very fine movements. These are myokymia. And this one in eyelid. Here you can see the twitching movement. The tics, they are usually started as a normal movement, but even after sometimes, just for example, head nodding. But even after removing the stimulus, they may remain in certain individuals. Asterixis, like what you, when you test the patient for a hepatic flap in cirrhotic patients, when you ask the patient to keep the hands like this and then hold for some time, but there is a flapping tremors, that is like the asterixis. There is a brief loss of posture, patient cannot maintain the same position. See here, it is flapping. एक हाथ लगभग गिर रहा है नीचे. Yeah, that is flap. मायोक्लोनस, जैसे मायोक्लोनस किसको मराठी में बोलते हैं दचका लगना, जैसे because of loud sound all of a sudden when somebody wakes from the sleep. But this could be pathological because of brain infection or infarction, infarctive pathology. See, there is certain sudden jerk movements. See, like this. Dystonia is a fixed postures when the body is twisted. What is twisted? Patient maintains a fixed posture. So it can occur in connector cerebral hypoxia, infection, tumor, vascular pathology.
गाडी चालवायचं चालवू शकता एक्सपिरियन्स पाहिजे असेल तर
आनयन ते कोणतरी येतील
कशाला माझ्या अभ्यासाचं राहू दे अभ्यास केला होता
See, when patient is maintaining posture, fixed posture here. See here it starts. Origin dystonia. Fits and convulsions, so the typical fits we all have some or other time noticed in patients of epilepsy. Sudden tonic-clonic seizures. There is salivation from the mouth. There is typically epileptic seizures. They are purposeless convulsions. This is not. So thank you very much for your patient listening. I designed this particular lecture for the benefit of students only. Hopefully they have benefited from it. So with the one practical demonstration speaks about 1,000 words, as said. So with a lot of demonstrative videos, I tried to explain the subjects and hope our audience, they have got the fair enough idea of the things. And those who want to read further, they can go through this integrated approach to clinical methods in Ayurveda. There is a lot of things described in this book, and they will find it very useful for them. Now, if there are any questions, we may take them, or we can have the chairperson's remark then.
Excuse me, sir.
Please ask, ma'am.
Yes, go on, please.
To what extent does diabetic neuropathic gestures or gait occur? After how much, what are the diabetic criteria, or what sort of things? How much?
Actually,
How
I got your point. What you want to
Yeah, yeah,
say
yeah, yeah,
when such type of action tremors or
yeah.
fasciculations will occur in
Diabetic
diabetes.
patients.
Yes. See, when there are, it is because of the chronic sequelae of the diabetes within long-standing diabetes, which is poorly controlled when there is a damage to the myelin sheath, and when there demyelination of the sheath occurs, it reflects in the form of first start burning of the right from the burning of the feet to the tingling numbness sensation, and there it starts from there to this type of fasciculations and the tremors after that, after the
Yes.
demyelinating complication. Hope you
How
got my
does
point.
insulin help in controlling all these things? Or if there is any damage in neurons, like peripheral neurons, can they be corrected, or by using some insulins or medication or proper exercise, fine exercises and all?
I got your point, but as of now, it is considered that the neurodegeneration is irreversible, but we can limit the
Okay.
extent of damage because on account of good
Fine.
control of the diabetes. Good,
Yes.
we may take help of the insulin. Uh, Lastly, actually, the insulin, many people they resorted to the as a last resort to control the blood sugar.
Yeah.
There may be some, but lifestyle changing measures, they help a lot, and they reduce the dose of insulin which is required. In fact, there are many centers nowadays which are running in the country, which are keeping the patient out of the insulin, only with correction of the lifestyle measurements, dietary and
Okay.
lifestyle modifications. Many are running such, and they have successfully reverted the
Yeah.
uh, or they reverted some, in some cases they have reverted diabetes, and in some cases they have a good control of the diabetes.
Okay.
But nevertheless, we can supplement B1, B6, B12. They are the best
Yeah.
vitamins
B1, B6.
for
Yeah.
neurodegenerative diseases.
Definitely, definitely. Yes. Thank you so much, sir. Very nice explanation. Very good presentation, sir. Very beautifully, you have shown the pictures and videos and all. You have revised your things in GAC Nagpur and all. Even I have gone through all those things, and it was very exciting learning all these things. And yes, of course, we are all students always, and we definitely have we gain very much inputs from all your these presentations. Thank you so much.
Thank you very much, madam. You being my senior and from my institute, you very well know the Ayurvedic hospitals. They are full of patients, neuro
Yeah,
patients under the name of
yeah,
Vata
neuromuscular.
Vyadhis.
Yes, yes. But
They are
then,
all neurological patients per se in the Vata Vyadhis. Under the name of Vata Vyadhis, our wards are full and packed of these cases, and we used to know all these things. We used to demonstrate all those things in our wards when I
yes,
used
yes,
to take the classes. When I was HO there, some of the individuals are here, maybe here. When I
yes,
taught
yes, yes,
neurology for hours together, standing.
yes, yes, yes. Of course, our teachers, they used to try to teach us everything, but then now it is clear with all the modern things available and materials, everything we study. And then, of course, these patients we come across. So it's very useful. Your lecture was very useful, sir. Thank you so much.
Thank you, madam.
Thank you,
Hemant,
sir.
see if there are any questions again in chat box.
Thank you, sir. Thank you so much. Very informative and elaborative lecture on gait and involuntary movements in neuromuscular disorders. I hope our PG students would have take a lot of benefits from this lecture. Thank you, sir. After this, I would like to invite today's chairperson, Dr. V.R. Poddar, sir, for chairperson remark.
Hello. Hello. Myself, Dr. Vijay Poddar
Yes.
here. Yes, listening here.
Yes, you are audible, sir.
Audible?
Yes,
Yes, sir. Thank you. First of all, I would like to thanks to Dr. Subhash Waghe to giving me an opportunity here as being as a chairman. Now, he has given powerful and very much interested topic, that is gait in the neuromuscular disorders. Particularly, he has attempted as possible present here. No, we know very well this topic is very much tedious and complicated, but we try to see with practical aspect point of view. Friends, we know the gait is the clinical examination for purpose to diagnose the motor neuron disorders, as well as by the help of this gait examination, we can decide the site of lesion also. Site of lesion, that is lower motor neuron lesion diseases are there, or upper motor neuron lesion is there. Even we can detect the very initiative cause of that particular nervous system disorders or neuromuscular disorders. We know what is the cause of gait may affect due to some diseases. Motor organ disorders or motor pathway is disturbance in the motor pathway. Lower motor neuron disorders, or there is some abnormal development in the bone and muscles. So we can observe how to walk the patient and their pattern or what the change in the pattern of walking. So it is very clearly in our ancient science, normal gait, and another one is the abnormal gait. By the help of abnormal gait, we can try to diagnose practically whichever the motor neuron disorders of lower extremities or any other motor organ disorders. We know very well, and we have seen many of the patients in our wards or indoors, hemiplegic gait, spastic gait, Parkinsonism gait, neuropathic gait, Korean gait, or rheumatic chorea gait, ataxic gait, or sensory gait, or alcoholic drunken, even that is a abnormal gait. That is or seizure gait. There are so many gait way of walking we can observe, and by the help of this clinical examination gait, we can diagnose or detect the very initial cause of disease, and we can decide the state of lesion of the disease, as well as we can decide whichever the neuromuscular disease is the perfectly. And one thing is here, from ancient times, we see from ancient times, our ancient physician, not only the ancient physician, today even orthopedic surgeon and neurophysicians also very concentrated observe the gait examination, how to walk the patient perfectly. And many of the doctors or neurophysician, or we people also can diagnose the motor neuron disease or lower extremity disease by the help of only gait, by the inspection of the how patient walk. It's very efficiently see number of patients in practically in our ward or in our patient in our OPD level. We can see observe. Then it may be going. That is a possible only. Another one thing is there. The abnormal gait is actually number of abnormal gait we can, for the diagnosis point of view, why the human balance of the body balance and irregularity of the muscular tone are important to know for this is far. Is there any technical disturbances are there? I think so. Human balance That is because of the mainly lesion is cerebellar, or another one is vestibulocochlear nerve also may damage, or control of muscle fibers is dependent upon these three organs. That is called and we must have to differentiate whether it is from lower motor neuron lesion or upper motor neuron lesion. And muscle tone is very important to see while we think about the gait. There is a muscle tone, it depends upon we can say the hypertonia or hypertonia, atonia or myotonia, dystonia. Hypertonic means spastic type of gait or spastic gait. And we know, we have seen the just videos even while the lectures delivering the Dr. Subhash Waghe here. The hypotonic, that is another one. Hypotonic means flaccid type of, or walking just like as a looseness, loose, and that is called flaccidity because of flaccidity in the muscle tone or flaccidity. So there are number of things we can have, but we must have to undergo, see the patient, number of patient, then only possible we can diagnose very perfectly by the help of this gait method, investigation method or clinical examination method. And for not only depend upon this gait, we can go further again for confirmation point of view, for the diagnosis point of view, investigations are also essential here, X-ray, MRI and so on. And whatever the advancement of the investigation, we can go for that and then try to diagnose the disease, such a type of motor neuromuscular disorders. I think this is a very nicely presented by Dr. Subhash Waghe. I am proud of you, and you are attempting do as possible presented here, and means number of video clips are given for us, and no doubt I am very honestly say our student this lecture is very important and valuable for our postgrad students and researchers. Thank you very much. Thank you very much.
Thank you very much, sir, for your comment and kind words. Thank you very much.
Thank you, sir. Thank you, sir. I would like to request Dr. Mangesh Udmale, sir, for a vote of thanks.
Thank you, sir. Myself, Dr. Mangesh Udmale, Associate Professor in Rog Nidan. Today, I feel immense pleasure to take this opportunity to propose as a vote of thanks on behalf of RVPGA Naidaniki webinar. Today's webinar renowned per speaker, Dr. Subhash Waghe, sir, given a very informative and knowledgeable lecture on the topic of gait and involuntary movement in neuromuscular disorder. Thank you, sir, for sharing your practical and clinical approach regarding the same topic to all PG scholar and participant. Thank you, sir. Thank you to respected Vijay Poddar, sir, as a today's webinar chairperson and giving some suggestive information. Thanks, sir. Thanks to Dr. Munal Bhoir ma'am for introduction of organization. And thanks to Dr. Archana Kulkarni ma'am for welcome speech. Also thanks to Maharashtra Council of Indian Medicine, Mumbai, for approval of Naidaniki webinar series. And last but not least, thanks to all participants. Thank you, all of you.
Thank you.
With permission of Secretary Dr. Hemant, sir, I declare that webinar is over. Thank you, sir.
Thank you, sir. Thank you.
Yes, we can close the meeting now.